We move to the next presentation. I think it's an expected trial, prospective randomized trial of NOTES Cholecystectomy versus Laparoscopic Cholecystectomy, presented by Dr. Kochman from the SAGES ACG NOSCAR Consortium.
So Schwaitzberg is presenting.
Okay, sorry, I apologize.
Good morning. I'd like to thank the Society for the privilege of presenting the results of the novel trial, the natural orifice versus laparoscopic surgery, on behalf of all the clinical trialists and study coordinators and my co-PI. Here are our disclosures. They're not relevant to this study. So most people have heard of NOSCAR by now, and if you think back 10 years, the initial focus was on transgastric procedures. The concerns that were unknown were about infection, gastric closure, peritoneal closure, tools, and the science behind whether this would be a viable technique in the next phase of surgery. The NOSCAR committee, through its wisdom or conservatism, declared that NOTES access was experimental, and there are a number of things that follow on, including this trial, from that decision. This led to a thoughtful, deliberate, evidence-based introduction of the technique. At that time, developmental work in the preclinical phase was funded by multiple industry sources, and this money was put into a communal bucket, and then the NOSCAR Research Committee would analyze and take grant requests and administrate independently of the funding sources. Over the next few years, reports of both transgastric and transvaginal cholecystectomy began to appear, and the NOSCAR Research Committee met with the Joint Committee of SAGES and ASGE, the NOSCAR Joint Committee, to make a decision about whether a human trial would be the next phase for us. With that, we decided to develop a clinical protocol, and we would argue and discuss and refine, based on some of the local IRB work that had been going on the aims, the trial design, the fundraising issues, the protocol approval problems, the research finance issues, and the study administration. The specific aims of this trial was to assess initially the safety and efficacy of transgastric and transvaginal cholecystectomy compared to conventional multi-port surgery. The second primary aim was to assess the pain differences associated with transvaginal and transgastric surgery when compared to traditional multi-port surgery. Secondary aims were to assess the logistics and tool use and cost associated with these procedures, and more importantly, to identify any unforeseen barriers to transgastric or transvaginal surgery. So here we go. So the trial design, very lofty goals, which why it took so long, would be a prospective, randomized, controlled, non-blinded trial to assess non-inferiority between conventional laparoscopic surgery and NOTES access. Originally, we planned to enroll 140 patients, 35 transgastric, 35 transvaginal patients, and 70 control patients. So we went off in fundraising, and so when we announced that we were going to do this trial, we actually didn't have any money at that time. So we started to go out and search for money and had multiple discussions with the NIH, NIDDK, AHRQ, the payers industry, and nobody was interested in answering the question, this clinical question of whether or not cholecystectomy access would be safe if we'd radically changed the approach to the surgery. The payers were just simply not interested, and it wasn't a high enough priority on any of the comparative effectiveness lists at the government at the time. We went back to industry and used our model of communal bucket funding and had 5 companies contribute to the NOTES trial and placed it in a bucket and allowed the NOSCAR Research Committee to function completely independently. There was no industry input to trial design of any kind. The study was designed to be device agnostic, and principal investigators at the local sites could use any of the tools that they wished to accomplish the procedure. In addition, both SAGES and ASGE contributed real dollars to the study bucket. Here are the sites, and I'd like to personally thank all of the trial investigators who participated. It's a long and arduous task to put together a clinical trial like this. Lee, I don't know how your site got bigger letters than everybody else, so that doesn't mean anything. It's just a typo. And really, their work is really what made the trial happen. So there were some fundamental decisions that went on with this, and that when NOSCAR made the decision that this is not the standard of care, we actually painted ourselves into an interesting finance corner and felt that it would be appropriate and important for the study to pay for the NOTES access cases, which is why it required as much as $1.7 million to execute and complete and administrate this study. On the other hand, patients who were randomized to laparoscopic cholecystectomy would be funded by the usual methods. This is a pretty high bar and created all kinds of interesting follow-on results, not the least of which is that negotiations with hospitals over the indemnification for major injuries was quite arduous. Hospitals did not have any appetite to take on unforeseen major complications as we embarked on this journey, results of which would be to be determined. In order to solve this logjam, we took a page out of the Bariatric Times, actually, and I discovered an ad from an insurance company who indemnifies self-pay bariatric patients, and we went to them and funded insurance for the major complications such as common bile duct injury and return to the operating room so that we could unbreak the logjam with not the IRBs, which were not much of a problem actually, but research finance organizations. Dr. Kochman and I were the principal investigators. Barbara Connell from ASG served as our administrative staff. We engaged a contract research organization so that we would manage the data professionally, and also commissioned an independent DSMB who reviewed the study at midpoint for safety and potential stoppage. So what were the inclusions? As you might expect, we were not looking for difficult patients. We were looking for elective surgery, adults, ASA 1 or 2, people willing to be in the trial, and I'll talk about that in a minute, and people who had not had significant operations to exclude them from the trial. Exclusions would be also pretty typical. We did not want to operate on children, pregnant women, cirrhotics, patients with extraordinarily large gallstones, and a host of other pretty sensible exclusions. So the trial begins. It got off slow because we didn't have any funding, but at that time also, this was really the peak of the single port rage, and so the NOTES enthusiasm started to flag a little bit as surgeons identified other ways of being less invasive potentially than their multi-port approach. In addition, the transgastric arm was closed for futility. Although there had been reports of successful transgastric surgery, the practical reality of this is that neither the tools nor the learning curve we were ready to really do this as a trial, and this is a very serious cautionary tale about the innovation pathway and when we can do clinical trials. And we closed the transgastric arm for futility after the completion of a small number of cases. But the trial continued predominantly as a transvaginal study, and although we did do a few transgastric procedures, there were no major complications. So patients who ultimately underwent any form of surgery were 79 patients. Those that stayed in the study all the way to 6 months was a little bit less, but every single patient we operated on stayed in the study for at least 30 days so that we could assess mortality, bleeding, return to the OR, common bile duct injury. Patients who discontinued the study was an interesting group. Often patients found the study because they have a preconceived notion that they wanted to have the transgastric or they wanted to have the transvaginal. And if they were randomized to control, they go, no, I'm not doing the study, and they went back to their home institution. And this was also one of the interesting lessons learned. What did we find? We found that the transvaginal access takes longer, but if we think about the innovation pathway and when we were doing the study on the learning curve, I suspect these clinically significant differences would ultimately go away with time, similar to what happened when we introduced laparoscopic cholecystectomy, but in the trial, it took significantly longer to do transvaginal or transgastric surgery. The median blood loss was the same. There were no deaths. There were no common bile duct injuries. Really, the study was conducted quite safely. For serious adverse events, one of the major endpoints of the study, there was one serious adverse event in the entire trial that was related to the procedure, and that was a patient who underwent transvaginal access. Their IUD was accidentally displaced as a result of the access. This was replaced later, and there were no other untoward complications. There were no deaths. So what did we learn about pain? This study was conducted as a hybrid trial with laparoscopic observation of the initial port access into the peritoneum, and perhaps even this small camera, 5mm camera in the umbilical port resulted in enough pain to wipe out any pain differences between the NOTES access and the traditional multi-port access. The pain scores improved in all groups, but in this trial, pain was not significantly different in either group. We studied dyspareunia, and many patients engaged in sexual intercourse before the moratorium for 4 weeks. And amongst those patients who engaged in sexual intercourse, there was no difference whether you had a transvaginal or a regular laparoscopic approach. One of the interesting findings was that we did SF-36 scores and cosmesis scores, but one of the interesting results was that the mental component of the SF-12, the transvaginal group, did better. And I'm not holding this out that transvaginal surgery produces a greater state of mental well-being, but it was a clinically significant finding in the study. So what did we learn from this? Transvaginal NOTES access is not inferior to multi-port access. That pain scores, return to work, major complications, cosmesis scores were similar in both groups, and the unexplained finding of mental component of the SF-12 we'll have to think about some more. NOTES access should not be considered experimental in the transvaginal group. Training is required to master this access. The transvaginal approach should not be a barrier to reimbursement. The lessons learned in this are many, that new procedures do deserve evidence-based evaluations. Fundraising for these studies is difficult. Professional societies as trial sponsors that are capable of answering clinically relevant questions is a viable approach. The challenges are formidable and they can be overcome, and that perhaps one of the most important results from this trial, that the opportunity for SAGES and ASGE to collaborate along the innovation pathway is as an important result of this trial as any of the technical results. I'd like to thank the PIs for their willingness to participate in the trial and go through this process, and a very special thanks to Barbara Connell from ASGE, who was our administrative support, who was the glue to make this study happen. Thank you.
Thank you very much. Questions?
From Portland, Oregon. I'm interested in the non-inferiority claim. Obviously when you power it, you pick an outcome that you're saying is non-inferior and, a percentage difference, and it doesn't seem like you would have enough patients to truly claim based on complications that this is non-inferior.
Well, we engaged a CRO for their statistical expertise, and the confidence intervals around the data shows that the study was sufficiently powered. Off the cuff, I completely would have the exact same results, but the study was adequately powered for non-inferiority based on the confidence intervals around the results and the tightness of the data.
On what outcome, though?
To equivalence, to unity.
No, but what did you, complications or pain or?
There's more data. So the rest of the pain, cosmesis, major complications, operative time was significantly different. All of the rest of it was no difference.
But in the power analysis, what was the primary outcome that the power analysis was done on?
Looking for a 10% difference.
In complications? Or?
In complications, cosmesis, pain, et cetera.
Jerry Freed from McGill. I actually wanted to follow up on that, Steve. It was a beautifully presented paper, but I think the real, equivalence is a very, very high bar to reach, and I think it depends on the outcome, that your primary outcome for which your study is powered before you can make that statement. And certainly if your outcome is something like bile duct injuries, we're way, way below the level where we would be able to say that it's safe. In fact, I think you can cluster all the outcomes. When you come up with a power analysis, you have to identify your primary outcome and base your N around that outcome. And I think in order to, to say that this is truly equivalent, that outcome has to be very clearly specified, and the study has to be powered around that.
Yeah, the major outcomes, Jerry, were pain and major complications. Even if you consider the single port trial that was performed single port, that didn't have enough outcome patients in it either to show, because you would need like 600 is when we powered it up for a superiority difference, and it was just unfeasible to power a trial to that extent.
My name is Edmundo from Peru. Thank you for your presentation. 2 questions. Would you please give us some more details about what means transvaginal cholecystectomy, to tell us the technique, the main technique that was shared?
Sure.
And the second one, in light of these results, what's the plan next?
What's the what?
That no scar plan. What is the agenda?
I'm sorry, can you repeat the question?
What are you planning to do? The people involved in NOSCAR, what is planning to do in light of these results, as a consequence of these results?
Sure.
Thank you.
The first one is easy. We did both rigid and flexible endoscopy as the source. Different groups did different approaches. The rigid approach was probably slightly faster and slightly easier than the flexible approach. But really the future of NOSCAR is a discussion. I invite you to the NOSCAR meeting this summer, and the incredible work for POEM, transrectal access is all sort of an offshoot of this joint venture and journey that the two societies have embarked on. Jeff.
Sure. Jeff Marks, Case Western of Cleveland. Steve, really nice presentation. One question, were cholangiograms performed in any cases, or was it indicated or desired to perform cholangiograms in any of the transvaginal access cases, and how was that performed?
There were a small number of cholangiograms that were performed through a percutaneous catheter approach.
Steve, can you comment on standardization of technique, issues like critical view of safety and that sort of thing in both arms of the study, really, but particularly for the NOTES access approach?
Yeah, I think that when you look at the sites that participated in the study, these were all extraordinary high-quality investigators who were committed to providing a critical view of safety. We have films of the different operations in the event that there was a major complication that we could go back and look. And as we know, the critical view of safety, when the angles are different, is more complicated to achieve. A few years ago, Silvana Parada presented an extraordinary paper of transgastric surgery with a complete misperception of the cystic and common ducts, which was identified before clipping. And so yes, the challenges and learning to identify the critical view of safety from potentially new angles is one of the things that has to be accomplished as well.
There's a question from the floor. Dyspareunia has been the concern for transvaginal for long term. Dyspareunia has been the concern for transvaginal for long term. Have seen anybody come back after 6 months with this complaint?
The longest patients stayed in the trial for the full 6 months. IRB requires any patient coming back with a complication like that, even if the trial period has technically ended, to be reported, and there were no reports of significant complications related to dyspareunia in the trial.
Any other question for the audience? Okay, then thank you very much.